The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and it's a pleasure to be hosting this podcast. And thanks to everyone for listening in. As you know, we're sort of in the middle of a special podcast series, and it ties to both a blog and podcast series I'm doing on my modest healthcare reform proposal. And that blog series started back in May, and I'll just sort of recount a little bit about the 4 blogs that I did. So on May 27th, my modest healthcare reform proposal at the blog tab of healthcarelabyrinth.com. On 6/10, I went deeper into my proposal and had 3 more parts. On 6/10 was price reform. On 6/13 was pivoting from utilization management to care management. And on 6/17 was my thoughts on affordable coverage as it relates to healthcare reform. The podcast series started on 6/14 with my modest healthcare reform proposal. On 6/21, I did price reform, so last week. And then on 6/28, we're now doing pivoting to care management. And on 7/5, I will cover affordable coverage as well. So that's just a quick update on the blog series on healthcare reform and the podcast series on healthcare reform. So again, today we are tackling pivoting from UM to CM, as I call it. And just to give you a little bit of a background, again, on my healthcare reform proposal, back on that blog on May 27th, I stressed that there were 3 cornerstones of reform: driving affordable universal access, reforming price, and pivoting to care management from our obsession with utilization management. So this week, again, I'm covering how we approach management of patients and really making that change from what I believe is sort of an obsession with utilization management over to what I would call care management. And I think of that more as population health as well as care management. Again, in that May 27th blog, I argue that America is obsessed with UM, or prior authorization. And that's essentially putting gates up to care in front of certain services. Not every service is prior authorized, but some services are very expensive ones usually, and ones that are abused and things like that. But again, that UM or that PA serves as a gate, and plans basically say to every enrolled member, you are going to have to ask me to get that service, regardless of what one of your providers may think and urge. And again, it's only allowed if the health plan authorizes it beforehand. Somewhat controversial, I will admit, but I will tell you, I do think prior authorization utilization management has a place in managed care. I think it saves dollars. It's very clear that members don't always know everything related to their care, and plans who are insuring them should have some say in what is covered. And I will also say that providers oftentimes are in a conflict of interest, and they may be recommending services to essentially make their income go up, or more importantly these days, drive the income related to their employers. And more providers are owned by private equity firms or health systems and hospitals. And so what a doctor may recommend is not always the best for the member, or it may be way too costly for the system. And so again, prior authorization sort of gates certain services, but I also say that prior authorization also gates the appropriate place of service. Sometimes a service is indeed appropriate, but maybe that service can be performed at a less costly center. As I told you, physicians more and more are owned by hospitals and health systems. And roughly half today of all doctors are employed by these hospitals and health systems. And there's a lot of evidence and studies that suggest that providers are driving people to these very expensive hospital outpatient settings or other hospital-owned settings in the community when things could be performed more cheaply at a physician office or another ambulatory center. So again, PA is upfront, may control whether a service is rendered, or more importantly these days, may control the place of service that service is rendered. So again, I think PA and has a role in efficient healthcare, but, and this is sort of where we're going with this podcast, and one of the three pivotal points of my healthcare reform proposal is that or PA should not be the main focus. It should have some focus, but it should not be the main focus, which I believe is what we have today. And again, this podcast is clearly saying, let's get over our obsession with utilization management and prior authorization and migrate to what is called care management or population health, managing the healthier population and managing the care of each individual member. I have often stated that far more could be saved if America invested in wellness, prevention, true care management, true population health, whatever you want to call it. There's no question in my mind that if we refocus dollars in our efforts on population health and care management, much more could be saved than just prior authorization. And I would also note that this pivoting is important because more and more government regulators are putting much greater and much more severe restrictions on prior authorization. The provider lobby in the form of the American Hospital Association as well as the American Medical Association have done a tremendous job in lobbying state legislatures as well as Congress on putting restrictions on prior authorization. They want those not because they're thinking of the health of the member, but because they want to make more money, in my view. And so they have gone to Democrats and Republicans alike at state legislatures and on Capitol Hill and won them over. I think lawmakers have been bamboozled by the provider lobbies into thinking PA is entirely bad and horrible and should be restricted and maybe even go away. And so hats off to these folks. They've done a good job doing that. I think it's to the detriment of the healthcare system overall, however. But it does now give a chance for insurers and health plans to say, I don't have so much I can do over on this and PA front. I have to jump through so many hoops, and that's an expensive proposition in and of itself, and it's getting worse and worse with more restrictions. Let me think of new ways to be cost efficient and drive quality, and that can be on that care management and population health side. So what does this model really entail? So we'll go for a couple minutes here before our first break, and we'll get into what this new care management pivot model here would entail. So number one, what population health and care management does is it really seeks to understand members' risks. As opposed to that upfront PA gate, they holistically look at the risk of the member. As we know, member risk can be divided between clinical and social determinant factors. Let's look at first clinical risk. And in this case, plans would evaluate the overall health of the individual, largely by examining the number of disease states or conditions and other healthcare events that a person is going through. We know that severity of disease states drive costs. Someone with a reasonably well-managed disease state may lead a very good quality of life and not drive a great deal of costs in the healthcare system. But we do know that as the disease states progress or become less controlled, or as people age, these disease states progress and become less controlled. That's when costs can increase exponentially and outcomes degrade. clinical risk models out there clearly show this. There are some leading risk models like DRG, ACG, and things like that. And those kind of risk models can be adopted to really look at the severity of various disease states from, fairly low risk to moderate, medium risk to high risk or very severe risk. I would also note that you can look no further as evidence of this to the dual eligible population. And that dual eligible population, if you remember, are individuals that are both eligible for Medicare and Medicaid. They are aged and disabled and in Medicare, or they are of somewhat low income and also qualify for Medicaid. These tend to be the poorest of Americans, but they also tend to be the individuals with multiple comorbidities and disease states that may not be in check. And again, these folks tend to be highly complex, both from a clinical and a social standpoint. I'm going to get to the social determinant and socioeconomic standpoint in a minute. And what's interesting about these folks is that latest studies show that they represent about 17% of Medicare beneficiaries and 14% of Medicaid enrollees. But they actually consume 33% of traditional Medicare spending and 32% of Medicaid spending. So in essence, they are spending about double their percentage of enrollment, or as much as more than double in the case of Medicaid. So a cohort of sicker individuals, 17 and 14% of Medicare and Medicaid, but they are consuming about a third of the expenditures of both programs. So here's a good example showing how the risk and the number of disease states and the progression of disease states certainly impact healthcare costs. Now, these clinical factors really impact all lines of business. Perhaps in Medicare and Medicaid, the impacts of these disease states are the greatest and the biggest cost drivers out there. But you also see this in employer coverage or group coverage, as well as in the commercial world. Those with more disease states in conditions or other healthcare events tend to, from a clinical sense, dominate spending along the way. Let's get to that social determinant front we talked about. So what do we mean by social determinants or socioeconomic factors in healthcare? Well, these are things like food security, housing security, transportation, health literacy, and other sort of factors out there that also tend to predict overall healthcare costs. Studies seem to show that these non-clinical socioeconomic factors not only also contribute to costs and outcomes, but in fact, these various studies suggest that social determinant factors can predict a majority of overall costs and outcomes in the healthcare system. And so these studies, again, there's various of them, but in general, they predict that about 50 to 80% of overall healthcare costs can be determined by non-clinical socioeconomic factors as opposed to the clinical disease states, diagnoses, and conditions and things like that. So that's sort of our first element of what plans would have to do. It's not to say they don't do it today, looking at the risk of the member, but in many cases, it's a little bit of an afterthought. There's not a supreme focus on analyzing risk of the members because of the obsession with And also, when many of this risk analysis gets done by a health plan, it's actually done more to drive revenue, for example, in the Medicare program for risk adjustment, as opposed to maybe really diving deep into how these risk models can help formulate interventions and help engage people in their own care or engage providers in enrolled panels care. So with that first element of population health and care management talked about, we'll take a quick break and come right back in about a minute.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Thanks, everyone, for joining today, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We told you at the beginning that we're in the middle of a four-part series related to my modest healthcare reform proposal. On 6/14, I, in a podcast, unveiled my healthcare reform proposal. Last week, we had price reform. This week, we're talking about population health and care management. And next week, we'll be talking about affordable coverage and universal access. So getting back to the podcast here, right before the break, we talked about the need in population health and care management to really understand the risks of members. There are risk models out there. There are clinical risk models that focus on disease states, conditions, and other healthcare events. And there are also models that take into account to help plans understand the socio-determinant or socioeconomic factors related to healthcare as well. Beyond investing in understanding the clinical risks of your population, a health plan next needs to invest in holistic care of members and engage them in a personal model of care or care plan depending on the clinical and social needs of the member. While plans will argue they invest here currently, much of the investment, again, is meant simply to drive star and quality scores and probably doesn't invest enough in the actual management and health of the individual. And so the engagement, again, is not rooted right now in fundamental care management engagement principles, in my view. It sort of dabbles in that area or seeks to drive certain interventions to drive revenue and star and quality programs. To me, a true care management paradigm shift would invest in both technology and care management staff to really do two key things. Number one, create a population health program with sufficient investments. That would mean actively tracking every member for social and clinical needs, as we talked about in the risk a little while ago. It would also pursue health and wellness opportunities. It would also adequately staff care resources for case and disease management intervention. And again, plans will argue we have this, but I don't believe it's at the level we need to have a true pivot. And then more importantly, and this is where I think many plans fail, they need to take what they learn in that population health program and risk discovery to truly engage continually with both members and providers to really drive care. And one last point on this pivot, plans really need to make major new investments in primary care and prevention. America is certainly not alone in having a primary care doctor shortage, but other developed nations have done a much better job of focusing in on primary care. We'll talk a little more about this a little later in the podcast. And so they have made the focus on primary care that America hasn't. More dollars are spent by other developed countries on primary care, and within primary care, you think of wellness and prevention as well. And again, here in America, we have a paucity of investment on the primary care side. We actually have an overinvestment in specialty care, and we really need more dollars allocated in primary care, wellness, and prevention. So just to sum up, the three sort of keys to creating a true population health and care management investment would be seek to understand members' risks, number one. Number two, invest in holistic care of members and engage people in a personal model of care or care plan. And number three, make major new investments in primary care, wellness, and prevention. This would really take a paradigm shift. There's no question about it. Breaking up this decades-long obsession with utilization management and prior auth and pivoting to care management would indeed be a huge paradigm shift. And I would note that it's not just health plans that would need to make this shift. The federal and state governments need to do more to prioritize primary care investments, from payment rates and what primary care receives to medical education in primary care and its importance, as well as to address physician shortages. Government programs, health plans, and employers would also together need to do more to ensure the establishment of primary care or primary medical home connections. Today, our government programs and our health plans do not do enough to really educate members and set up an appropriate infrastructure of primary care medical homes or attachments to primary care providers. And sadly, that is the root of a lot of costs in our system by not establishing those primary care homes, so to speak. And that is also a good portion of why outcomes, again, are so poor, because wellness, prevention, and disease states are not monitored well enough from the primary care standpoint. So with that, we're going to take our second break here, and we'll come back for the balance of the podcast.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back again from the second break, and we hope you are enjoying this podcast about pivoting to care management as one tenet of my healthcare reform proposal in this series. Many people will doubt that a pivot from UM to CM can work, but I'm here to tell you it can work. Making the shift from UM to CM would take time and resources, but the benefits are huge on both the cost and the quality front. As I noted in my May 27th blog, America spends the most on healthcare in the developed world by far, 35% to 97% more than developed countries, and about 80% greater than the Organization for Economic Cooperation and Development average. Further, as I noted, it has the worst outcomes by far. And I'm a bit embarrassed to say that we are an outlier even on the bottom side of the low performers in the developed world. And that's really something we have to think about. And a lot of this is really rooted in the lack of focus on care management and primary care and wellness and prevention. Take some of these findings from the Commonwealth Fund and Peterson KFF Health System Tracker, all of which I tie back to the lack of investment in primary care, wellness prevention, and care management again. U.S. life expectancy is 3 years lower than the OECD average. Avoidable deaths per 100,000 population in the U.S. are 50% higher than the OECD average. The U.S. has the highest rate of infant and maternal deaths within the OECD. The U.S. rate is 32% higher than the OECD average for infant deaths and 143% higher than the OECD average for maternal death. That's actually amazing in our technology-driven healthcare system that we are such outliers in these areas of infant and maternal deaths. The U.S. obesity rate is nearly double the OECD average. And here's where some of the cost driving occurs. Because the U.S. does not invest in primary care wellness and prevention and oversight of disease states, U.S. hospital admissions for congestive heart failure are higher, and so are diabetes hospital admissions than comparable countries. These rates are demonstrably higher than those other developed countries. They're about 114% higher for congestive heart failure and 133% higher for diabetes. Adults in the U.S. are the most likely to have multiple chronic conditions. Again, because of our lack of investments, these conditions tend to spiral out of control and drive higher cost areas of healthcare. And both the number of participating physicians and physician visits are 30% below the OECD average. Now, there are, as I've stated, physician shortages throughout the world. But it's very clear that our shortages and our investments in critical areas are much worse. To make matters worse, again, the U.S. has many more specialists than other developed nations, and a lot of our medical students want to go into specialty areas because they don't understand the value of primary care, and they are sort of lured by the almighty dollar to these higher reimbursing specialist areas. And I make the case in my book, The Healthcare Labyrinth, that we really need to tackle that by paying primary care physicians more and de-emphasizing specialties to some degree, because they are commanding much more cost than primary care visits, for example. Now, the news is not all bad. For example, we do better on breast and colorectal cancer screenings because of the emphasis we put on it in America. Our hospital length of stay is lower, although, again, our admissions for uncontrolled disease states are much higher. Certain hospital outcomes are better in America, although some are worse as well. But in general, the statistics I've just stated point to a fundamental failing in the area of primary care, prevention, and disease management. It is clear to me that our lack of focus here leads to considerable cost and our poor overall quality outcomes. And that is why pivoting from and prior auth to care management is on my list of 3 important tenets of healthcare reform, along with price reform and affordable universal access. With that, we'll end this edition of the Healthcare Labyrinth Podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.